The objectives of this talk are, first of all, to improve the technique of transvaginal pelvic scanning so that we can optimize our accuracy of interpretation. We're going to re-examine the steps during the transvaginal scanning procedure and pinpoint where errors in interpretation may occur, and correlate the different positions of the uterus in the pelvis with the transvaginal sonographic images for a better understanding. So basically, think about how you do a transvaginal scan. You start from the beginning with the history, so to avoid the pitfalls, you want to know the correct OBGYN history. You do want to start with the transabdominal pre-scan. Then once you're doing the transvaginal, you want to understand your image projection. Make sure that you have the correct beam orientation. Check your different points of technique. Then as you scan, start with the bladder, the cervix, the uterus itself. Know the blind spots in the pelvis. Be persistent about finding ovaries. Maneuver the probe in different ways. Use Doppler at the end, and think of think of things beyond gynecologic conditions. All of these in a stepwise fashion we will discuss here in this talk. First of all, know the OBGYN history. It's very important, especially in gynecologic and obstetrical history, to know the age of the patient, to know the parity of the patient, the date of the last menstrual period, the hormonal status of the patient. Is the patient on any specific kind of hormones for fertility treatment, for replacement therapy, for has had chemotherapy, any type of agents that could affect the the appearance of the reproductive organs, any special circumstances in this patient, and listen to the patient. Ultrasound is one of these areas where we actually do still have patient contact, and while we're scanning, we can hear more detail about the patient's condition and look for the abnormality actively. As far as knowing history, when we have a situation of pregnancy, it's very important to know, have there been any pregnancy-assisted techniques, because this puts us on a special alert because of the possibility of heterotopic pregnancies. In patients who have undergone ovulation induction, the risk of heterotopic pregnancy is about 4%. And 1% of pregnancies with IVF and gift procedures end up to be heterotopic. So we don't just look at the intrauterine pregnancy, we look outside in the adnexal regions. In this case, there was ovulation induction. We see an enlarged ovary with cysts, but because of the risk of heterotopic, we look carefully and we spot that not only was there an intrauterine pregnancy here with an embryo, but there was an extrauterine gestational sac and ectopic pregnancy, and the rest of the ovary was out here. So yes, that would alert us. We have to know this information. Now, as we're scanning the patient, here's we listen, and in this situation here, the patient is telling us that the pain is not really in her pelvis. It seems that the pain is in her abdominal wall. She came as a pelvic ultrasound, but we change our transducer to a high-frequency linear probe, and we scan the area of pain, which was in the abdominal wall, and here we see a mass that ends up So doing a biopsy on this solid mass in the abdominal wall, it turned out that this was metastatic sarcoma years later in a patient who had abdominal wall pain, not specifically pelvic pain. Another way to avoid problems, pitfalls, is to pre-scan transabdominally. Now, transabdominal pelvic sonography in its pure form is no longer really practiced. What we're talking about here is still to take a look at the pelvis transabdominally, but not necessarily to have a full bladder. A full bladder is not necessary anymore. So we can have a patient come in a natural state. Bladder could be empty, bladder could be partially filled. Put her on the table, take a quick look around the pelvis, looking for a large mass, a large uterus, something that could easily be missed by just doing transvaginal sonography. So when we schedule these patients, they just come in a natural state. We look at them quickly, spot fuse transabdominally, have them empty the rest of their bladder. In the meantime, quickly set up the transvaginal probe and do the examination. We do have some evidence from an article out of Boston in a study that they did on 206 patients. Transvaginally, when they did transvaginal alone, that was sufficient to visualize all of the significant findings in about 85% of patients. That meant that an additional 15% of patients still required a transabdominal scan without a full bladder to get the information. Only 1% of them actually required filling of their bladder. So if a patient comes with an empty bladder and happens to be in this very low percentage that she would need a full bladder, we will then have her drink and fill her bladder. This may happen, for example, in a very young girl, a virginal patient, a very old patient who cannot tolerate a transvaginal exam. But that will only be a very small percentage of patients that have to sit and wait and fill their bladders. The value of doing this transabdominal pre-scan is that it gives us a general pelvic overview. We can quickly estimate the uterine size and see, will we have trouble imaging this uterus with the transvaginal probe or not. We can look for a mass above the fundus of the uterus, such as a pedunculated myoma or a large ovarian mass, or even an ectopic pregnancy in a high position. And we can quickly assess for intra-abdominal fluid with the same probe. If you do transvaginal sonography only and bypass this step, you are liable to miss or misinterpret a large mass, incompletely scan a large uterus, miss an intrauterine pregnancy or an ectopic pregnancy or a mass in a high location, misinterpret an ectopic as an intrauterine pregnancy. That's something that is unusual but could possibly be done. Or miss a large hemoperitoneum by not checking the right upper quadrant. If you scan only transvaginally, as in this case here, you could miss a large mass. Now, this looks like a perfectly normal uterus. However, the transabdominal pre-scan showed us that there was a large mass somewhere up high above that uterus, and even here on an extended field of view scan, we see that it is a very large mass. It's actually a pedunculated myoma attached to the fundus of the uterus. If you just started with the transvaginal, how would you know that there was something attached to the fundus of the uterus? So we go systematically from transabdominal to transvaginal. Now here's another one. If you just did transvaginal, this looks like a somewhat small uterus. There seems to be an endometrial lining here, but this was actually a very long uterus on the pre-scan, and when we knew that, so we were questioning this. Where is this only measured about 4 centimeters. Where's the rest of that uterus? So we knew that it was about 11 centimeters long. We searched more carefully, opened up the depth, found that it was really retroflexed, and found the entire uterus. What we were actually looking at was only the cervical part, and we were not imaging the corpus at all. Here's another example. Here's a transabdominal pre-scan that showed us a very high location of an ectopic pregnancy. And so therefore, when we looked transvaginally, we were very careful. If we wouldn't have seen it, we would go back transabdominally and study it in more detail.